This session in particular is going to be pretty heavy because my task is to talk about both the past and the present of what we have done for bone marrow failure in patients with telomere myology disorders. And it's going to lead into a couple of exciting talks by Dr. Myers and Dr. Agarwal that are going to go through some modalities that we're going to have in the future, maybe, that will put us onto a good place. I just want to warn everybody that we're going to talk about some of the past experiences, and some of those can be pretty heavy. So the first point that I want to make is when we're talking about bone marrow and we're talking about TBDs, I want it to be absolutely clear that there's not one screening program, there's not one trajectory for all patients that are affected by TBDs. There are many distinct syndromes that are under this umbrella. Different genes might have different risks. And then for certain people, screening interventions such as bone marrow biopsies carry distinct risks than they do for other people. So if you take nothing else from this, is your screening, your treatment really needs to be individualized if you want to. And one of the reasons for this is we now recognize the spectrum of diseases that we are dealing with when we're talking about TBDs. So when I first came here, a dozen years ago to Camp Sunshine, the predominant phenotype that we were talking about at the time was dyskeratosis congenita. And dyskeratosis congenita is really the combination of bone marrow failure along with new cutaneous features such as abnormal nails, mouth ulcers, which are called hematopoietic, and then characteristic skin phenomena as well. But what we've really learned over the past decade or more is that there are many other forms of telomere biology disorders which may have distinct risks related to bone marrow failure. Right? There are some patients that predominantly have hematologic issues, particularly in adolescence and adulthood. There are others that have a spectrum of diseases starting in early childhood. There are others that won't have any manifestations and won't be diagnosed with a TBD until they're in adulthood, when they're dealing with liver or lung issues. And then one of the biggest new presentations that we're dealing with in the clinic is when patients go to genetics because of features such as perhaps immune problems or neurocognitive delays in early childhood. Exome screening is coming up with genetic mutations and TBD-related genes. And these patients have no issues in terms of looking at their blood counts. And so how to predict what's going to happen in terms of bone marrow failure for those patients is very tricky. So what do we know about how many patients with TBDs will develop severe bone marrow failure? Well, apropos of the last slide, almost all of the data that we have, really good longitudinal data, deal with these classic presentations of TBDs. So essentially patients who have dyskeratosis congenita and some of the other well-recognized phenotypes. And some of the data from this really comes from the NCI, work by Dr. Savage and Dr. Alter, and when they're looking at cancer incidences. But they were able to collect the incidence of needing to go to bone marrow transplant as well. And that's a great surrogate for patients who have developed severe bone marrow failure. So in this cohort of nearly 200 patients who have more classic TBDs, what we found was about a third of patients needed to go to transplant for severe bone marrow failure. And if you look at this over the course of the first 3 decades of life, you see that the risk goes up a little bit as you get older for the development of bone marrow failure. Now, notably, the risk of developing MDS happens a little bit later in patients. So we see bone marrow failure starting in the first decade or 2 of life for patients with TBDs, whereas the risk of developing MDS really doesn't kick off until you're in your early adult years. So what do we know? Well, we know that patients who have the classic TBDs, about a third to a half of those patients may end up developing severe bone marrow failure. What we don't know is in patients who have the classic TBDs, what's the landscape of moderate? So patients may not develop bone marrow failure to the extent that they need bone marrow transplant, but they may develop some type of phenotype that can affect the quality of life. And so this isn't very well captured in the currently available data. And then what we really don't know is in the patients who have these more recently understood forms of TBDs, we really don't know what the risks are of developing moderate or severe bone marrow failure. Now, fortunately, there are a lot of new multi-center registry efforts underway, including through the CCC-TAA consortium that you'll probably hear a little bit about more later. And I think the goal of these efforts are really going to be to capture, incidences of developing bone marrow failure in these non-classic forms of TBDs that we've recognized more and more over the past decade. So when do patients with TBD develop severe bone marrow failure? Well, probably the most important factor that goes into this is what the gene is that's affected that's leading to the TBD. And we now know that there are patterns. There are some patients with certain types of mutations that are going to develop bone marrow failure very early in life. So mutations associated with TNF2, two copy mutations, so both parent copies being affected with mutations on things like TERT and PARN. These are early childhood. Now, there are a number of genes where if you have mutations, you might start to develop bone marrow failure in adolescence. And this includes biallelic or two copies of RTL1. This includes exon PKC1 as well. And there are more forms of TBDs where you may never develop bone marrow failure, or if you do, it's not going to happen until mid-adulthood. Now, these are generalities, but the critical element of this is that there are variants off of this time course as well, right? Because everybody has genetic modifiers, everybody might have different environmental triggers that might alter these generalized patterns. So if your family is affected by a gene mutation that doesn't fit into this category, then it's likely that one of those other external features are affecting that. Now, one thing that I often get questions about from some of our referring physicians is how do you define severe bone marrow failure in patients with TBDs? And the bottom line is that this is different than many of the other syndromes and diseases that we take care of. It is rare, even with patients who have normal blood counts, that if you look at the bone marrow, it would be rare to see a bone marrow that has normal cellular, which is what's shown here on the left-hand side, a bunch of those nice blue cells being made. Most patients with PBDs, even if the blood counts are okay, will have hypocellular marrows or even aplastic marrows, which is the medical term for marrows being empty. Empty marrows in and of itself don't define severe bone marrow failure, because we've seen time and time again that even if the marrow looks pretty empty, patients are able to maintain production of blood counts for years, if not even decades, as well. So it's very important to combine what's happening with your peripheral blood counts in addition to what you're seeing in the bone marrow to define what severe bone marrow failure is. And the definition that we use for severe bone marrow failure comes from the definition that we've developed for patients who have what we call idiopathic aplastic anemia, which is, yes, you have to have an empty bone marrow, but you also have to have two severe cytopenias out of the three major lineages of bone marrow cells. So very low neutrophil count, a very low platelet count with transfusion dependence for platelets, and a very low red blood cell count as well. So how do we screen for bone marrow failure? Well, when Neil Giri and I got together to write the screening chapter for pediatric patients for TBDs, we decided that we needed to recognize that there are patients with different degrees of certainty in the diagnosis of TBDs that are coming through. That degree of certainty really can dictate what interventions we do for bone marrow failure screening. So patients in whom we're sure of the diagnosis of the TBD that we know can be associated with bone marrow failure in childhood and young adulthood. And so these include patients with very short lymphocyte telomere lengths and at least one of the following: either you have the presence of a known problematic or pathogenic mutation in the TBD gene, or you have classic features of a TBD syndrome, such as dyskeratosis congenita, and a couple of the others that I think Dr. Bertucci is going to talk about later today. If you have these, we recommend full screening in terms of for bone marrow failure, and that's going to include invasive procedures such as bone marrow biopsies. The second category that we came up with for the Team Telomere guidelines are patients who should probably have partial screening. So these are patients that we suspect to have a TBD, but in whom the disease has not been genetically confirmed, or they don't fit the classic phenotypes of some of the syndromes that are associated with TBDs. Or it might be patients in whom the identified TBD-associated gene variant is not thought to cause severe manifestations in the pediatric age range, right? So examples of these include patients that we'll see where the lymphocyte telomeres are around that first percent, suggesting that there could be a TBD, but we're not very certain. They may have limited features of the TBD outside of the hematologic system, and then they have variants of uncertain significance on gene or genomic testing. So we're not 100% sure of the diagnosis. And then another example of this is if you have a patient who has just one copy of an RTL1 mutation or one copy of a PAR mutation and blood counts are normal, those patients may not have severe bone marrow manifestations of their disease until old adulthood, and so we don't necessarily begin the invasive screening for those patients in childhood. So everybody who has been diagnosed or is suspected to have a TBD should undergo regular hematologic screening, and this includes at a minimum blood counts being checked every 6 months. And blood counts help you not only for screening for bone marrow failure and MDS, but as many of you know, there are certain subtypes of TBDs that can be associated with problems in the immune system, and that immune dysregulation can lead to altered blood counts. And then also there are subsets of TBDs that can be associated with bleeding risks. And sometimes you can detect bleeding early by monitoring blood counts as well. So if you identify cytopenias, then that means that you intensify the frequency with which you screen the CBCs from anywhere to every 1 to 4 months. If you have mild to moderate cytopenias, and if you have severe, you want to go to very close monitoring. And so your monitoring frequency is told over a matter of weeks. So my practice is for patients who fall into the partial screening cohort, and they have severe normal CBC or several normal CBCs, excuse me. These patients may actually not need CBC screening more than yearly if we think that they're at low risk for developing bone marrow failure. The most controversial aspect of screening for bone marrow failure is what the role of bone marrow monitoring is, bone marrow aspirates and biopsies. There are a few things that we can get from looking at the bone marrow that we can't get from looking just at blood counts. We're able to look at how healthy the production of blood cells is by looking at the size and shape of a lot of the cells in the bone marrow. That's important. We can look at the cellularity to see how many cells are being produced, and that's important. We can look to see if there's scarring in the bone marrow, which is what we call fibrosis, also important. And then we can more sensitively detect genetic changes that we're going to talk about in a minute that can put you on the path towards developing MDS. So generally speaking, for patients in whom we were certain of the diagnosis of a TBD that can affect the early life, we do a bone marrow biopsy at diagnosis. Now, for patients who are diagnosed in infancy, we sometimes defer that until they're a few years of age. But otherwise, we do a bone marrow diagnosis. And then if it looks pretty good, and if you're a very small child, then we can defer bone marrow screening until a little bit later in life. But usually by the age of 10, we recommend yearly screening for patients. Now, this is controversial because when patients transition to the adult world, that screening recommendation doesn't always hold, and there are many adult practices who monitor blood counts only, and if there is a significant change, that's what triggers a repeat bone marrow biopsy, and that's okay too. This is a question that's still out there in the field: is how often should we be screening bone marrows for patients? For patients in whom fit that partial screening category that I mentioned a little bit earlier, we still recommend a baseline study, and sometimes that baseline study is useful diagnostically to see if patients have a completely normal bone marrow versus if they have some reduction in cellularity as well. And so that's one of the reasons why a baseline study makes sense. But if the baseline study is normal and the blood counts stay solid, we generally defer ongoing screening for those patients unless new blood count abnormalities. And then the last piece that I'll say about screening is don't forget, particularly in young children, some baseline immunologic screening. And it's important because patients can be at risk for infection. Many patients with TBDs will have some abnormality in immune function as well. So we like looking at the total numbers of cells that are involved in the immune system. We like to look at how well the immune system is producing antibodies. And we like to look at how well you respond to vaccines, all as a marker for how well the immune system is functioning for patients. If the screening is abnormal, we really strongly recommend establishing care with a local or a regional immunologist if it's available to you. And it's important to note that immune function can evolve over time for patients. This is rare, but once in a while, some of the patients who present with TBDs, particularly those who present very early on in childhood, can have severe immune deficiencies. And sometimes that severe immune deficiency, more so than your blood counts, may be the thing that dictates whether or not you would be a candidate for going to bone marrow transplant. All right, short of a bone marrow transplant, are there things that we can do to try to help bone marrow function in patients with TBDs? Well, the only proven class of medications that can improve blood counts in TBDs are androgens. So many of you guys are familiar with this. There used to be two different androgens that were available in the United States. Now the main one that's available is danazol. In Europe and Latin America, nandrolone is also used as well. The bottom line is that androgens can improve blood counts in up to 50 to 70% of patients. The blood count that tends to be affected the most is your hemoglobin. So this can go up by about 1 to 2 grams per deciliter. That may not seem like a lot, but sometimes in some patients that may be the difference between needing transfusions and not needing transfusions anymore. And so it can be a useful tool there. Some patients will also have improvements in platelets and neutrophil responses as well, but these are a bit less consistent. The expectation shouldn't be that if you start the androgen therapy, you're going to fully normalize blood counts. That is certainly a rare outcome, as Dr. Savage and others that have studied this have shown. The problem with androgens is that it can cause many problems, right? So, androgens are the types of drugs that used to be used by performance athletes until they were banned from using them. And so some of the things that you may have heard about in some of those athletes can happen here as well. You can get virilization or masculinization, and this is particularly a problem in young children and in females, where you can get abnormal patterns of hair growth, you can get premature pubertal changes, you can get acne, a variety of other things. You can also see behavioral changes sometimes with androgens as well. And the most concerning thing that we can see with androgens is liver problems. Now, sometimes those liver problems are as simple as changes in the enzymes on your liver function panel. It's a blood test. But some patients can develop benign tumors, which are called adenomas. And then very rarely, there's an association with a certain type of cancer as well. So androgens can work to help blood counts, but they come with all of these caveats. And so how do I approach androgens in patients with TBDs? I don't use until patients have or very near severe bone marrow failure, because as I said earlier, patients who have moderately decreased blood counts may persist there for years without blood counts falling further. And it's not until the counts are approaching that severe bone marrow failure range where we want to think about things that we can do to try to bring them up again. I view androgens as useful as a bridge for a defined period of time if there is a bone marrow, right? So if there is a social or an access barrier to stem cell transplant, for example, I've had in my practice before this come up where the sibling donor for a patient was away in the military, and he wasn't going to be able to come back for 6 months to a year. So, that's a defined period of time where trying something like androgens is reasonable. The other situation where this comes up is where families are attempting to make a new donor. When that happens, using antigens to try to support blood counts makes sense while waiting for that new donor. It's also useful if a patient is not eligible for stem cell transplant. In my personal practice, and I'm not speaking for everybody else here, I don't recommend indefinitely delaying transplant if you have a good donor to continue antigens. There's another class of medicines that have been used. These are hematopoietic growth factors. Just in the interest of time, I'll say there are anecdotal reports where these have provided benefits, but unfortunately, overall experience has been disappointing, and these medicines have as a potential risk increased clinical progression towards MDS, which is a segue to the next piece that I will mention. This is a point of confusion for many families of how MDS and leukemia are related to bone marrow failure. And the way I like to think about it is that these things exist on a spectrum, right? Where bone marrow failure is the first sign of stress in the marrow. The bone marrow adapts by creating mutations in your bone marrow cells to try to restore blood cell production. Early on, that causes the changes in the blood cells that are associated with MDS, but eventually that can lead to leukemia. On the upper left here is a nice diagram by Coleman Lindsley from a few years ago that I still like to show. What happens is when you develop bone marrow failure and cells are under stress, there are certain cells in the bone marrow that have developed mutations, and sometimes those mutations have the benefit of allowing that cell to continue to make blood cells. And what can happen is that cell that has the mutation can grow into a clone, and that clone can be selected for and can grow and make up more and more of your bone marrow population. What can then happen is that clone can develop additional mutations, and it's that acquisition of additional mutations that leads the cell to go on to developing MDS leukemia. We have studied this in our group at Penn and Shaw, and what's notable is that there are some clonal hematopoiesis is very common in patients with tumor biology diseases, but in some patients it can stay stable over a long period of time. So developing one mutation does not mean you are necessarily guaranteed to go on to develop MDS or leukemia, but there are certain types of mutations that have a higher risk for leukemia. So the dividing line between clonal hematopoiesis and MDS in TBDs is tricky. And there are a few different things that we use to try to sort that out if possible. We do know that if true MDS develops, the risk of eventual progression to leukemia is high. So just wanted to point out this study that was led by Daria Babashuk at Penn, a longstanding colleague of mine, and that was supported through Team Telomere in the $1 Million Bike Ride, where we tried to look at patterns of clonal hematopoiesis and determine how they impact the risk of going on to develop MDS leukemia. So we had around 166 patients. And this is through collaborations with many people in this room. So thank you all for this collaboration. And what we found in this study is that clonal hematopoiesis is present in about half of patients who have tumor biology disorders, but MDS really only occurred in about 15% of these patients. So we know that there's a difference between developing clonal hematopoiesis and moving on to develop MDS. We found a few different patterns of clonal hematopoiesis. And so they're color-coded in this chart here. So the ones in orange are when you develop changes in the chromosomes themselves in the cells in the bone marrow. And some of these are bad, and some of these are actually okay. The ones that are in purple at the bottom are the ones that we always worry about because those are the ones that can be associated with MDS. And the ones in the middle are particularly interesting, the ones in blue and the ones in green. So the ones in blue are mutations that actually help to restore the function of bone marrow cells by protecting those cells from the effects of the gene mutation that you were born with in the first place. And the ones that are in green are mutations in what we call DNA damage responses. And these mutations actually help the cells as well because they help the cells avoid the programmed cell death that happens when telomeres get too short. And so the discovery of these mutations suggests that this might be able to be harnessed in a way to be able to come up with therapy in the future. So bottom line with this, and I'll end this part of the talk with this, which is there are certain types of clonal hematopoiesis that we now think might actually be beneficial for patients. There are certain that are associated with high risks of MDS, and there are some that are in between. And so the bottom line is clonal hematopoiesis is pretty common, but you need to discuss with your team if it develops, and your team will hopefully discuss with the Team Telomere Centers of Excellence how to interpret what these changes include. And so the bottom line is when to pursue transplant in patients with TBDs. Indication number one is severe bone marrow failure, transfusion dependence, or very low neutrophil counts. Indication two, as I mentioned, is the immunologic reason for doing it, severe deficiency of the immune cell called T cells, or severe immune dysregulation, although this latter is very controversial. And then the third indication is certain types of clonal hematopoiesis. So the development of MDS means you should go to transplant. And there may be some clones of clonal hematopoiesis that have high risk of progression. And these are the things that you should discuss with the Team Telomere Centers of Excellence. And then I'll just end talking a little bit about outcomes of transplant and hopefully something more for the future. Back in the 1990s and 2000s, transplants didn't work very well for patients with TBDs. We tried to use traditional regimens that we call full intensity or even reduced intensity regimens. And many people didn't survive these because of complications in the lungs, complications in the liver, bleeding symptoms, and a few other things. One of the first steps towards progress was actually made by the Minnesota group and Jacob Tolar and Drew Dietz, where they recognized that we need to reduce the amount of toxic chemotherapy that we include in transplant regimens for patients with telomere disorders, reducing alkylating chemotherapy and radiation, and introduction of a particularly helpful immune suppression drug called alemtuzumab or Campath. This led to improved outcomes for patients in their small study. And then the major transplant breakthrough was really done by Dr. Agarwal, who's here in the room, who suggested that maybe we don't need those types of agents at all in your transplant regimen for patients with TBDs. And so Dr. Agarwal's conducted studies both at Boston and a multi-center study that has involved 40 patients and I think is just waiting final data points to be published. And this has greatly improved the outcomes of patients with TBDs who are fortunate enough to have a identified sibling donor or an unrelated donor for patients with transplant. So the challenges that remain for transplanted patients with hematologic disorders is we still aren't sure what the best approach is for doing transplants when your best available donor is a half-match donor. We also don't know what the best approaches are for patients who have progressed to MDS. Sometimes you need a little bit more intensity of the regimen to make sure that the MDS doesn't come back as well. And then we've also recognized that there are a small fraction of patients who get this low intensity conditioning who don't do well with it because their immune systems are a little too strong and they can reject the donor cells. And so we have to figure out for those patients how we can identify them ahead of time so that we can modify the conditioning appropriately. And then really the next step, I think, to solve a lot of these problems is to utilize some tools that we've used at CHOP, which is what we call graft engineering, which you can take the cells that you get from the donor and modify them in ways to optimize the immunologic content, get rid of the cells that cause graft versus host disease, keep in the cells that help you fight infections and those things. And I think as we approach the best ways to do half-batch transplants for patients, I think that sort of strategy is going to be useful. All right, I think I'm going a little bit longer than I wanted to, still under 30 minutes, but I'm happy to take any questions that you have.